Usually, when we talk about a low platelet count, the immediate instinct is to just brace for bleeding. It feels totally intuitive, like you lack the corks, the bottle is going to leak.
Right, yeah. It's the most basic mechanical assumption we make in hematology. Less clotting factor naturally equals more bleeding.
But then, you step onto the wards or you open an MCCQE clinical vignette, and suddenly that logic just completely flips on its head.
Huh.
You've got a patient with dangerously low platelets, and instead of bleeding, they're throwing massive life-threatening blood clots.
Oh yeah, it's a hematological paradox that breaks everything you think you know about blood.
And that paradox is exactly what the exam writers use to separate the candidates who just memorized a list from the candidates who actually understand the underlying pathophysiology. Welcome to the Deep Dive. I'm Harvey.
And I'm Donna. We are MCCQE reviewers, and our goal is to help you, the Canadian medical student, feel much more comfortable with the exam review process.
We'll be breaking down all major concepts covered on the exam. Today we are teaching from reliable StatPearls articles, focusing specifically on the hematology section, S06, and looking closely at platelet and vascular wall disorders, specifically thrombocytopenia.
But before we jump into the pathophysiology, we need a quick but crucial disclaimer. This is for medical education only, not medical advice. Clinical decisions should always involve a qualified healthcare provider.
Right, definitely. So our mission today is to equip you with the high-yield definitions, the clinical presentations, diagnostic pathways, and the management strategies for thrombocytopenia. And most importantly, we are going to dissect the common traps that test makers just absolutely love to use.
Well, let's establish our baseline first. For adults, thrombocytopenia is defined as a platelet count below the lower limit of normal, which is 150,000 per microliter.
Let me stop you right there, because 150,000 is really just a starting line. Before we figure out what causes the platelets to drop, you need to firmly lock the exam-relevant thresholds into your memory.
Oh, absolutely. The numbers are everything on this exam.
Right. So I like to think of the platelet count like a hospital's operating budget. At 150,000, things might be a little tight, but the hospital runs perfectly fine.
Yeah, you wouldn't even notice a problem day to day.
Exactly. But as that budget drops, the systemic risks change dramatically.
It's a solid framework because the clinical manifestations correlate directly with those specific numerical thresholds. So the normal lower limit is 150,000. When a patient drops below 50,000, that is your first major red flag.
Because that's the surgical bleeding risk, right?
Right. The surgical bleeding risk significantly increases. You simply cannot safely perform major invasive procedures at that level.
So at 50,000, the hospital budget is stretched so thin it can't handle the sudden massive crisis, like a trauma or a planned surgery. But it can still handle routine maintenance.
Exactly. But then we hit the absolute critical threshold, which is 10,000. Under 10,000, you are looking at the risk of spontaneous bleeding.
Oh, wow. So just out of nowhere.
Yeah, the internal infrastructure just collapses without any external provocation whatsoever.
The patient could literally just start bleeding into their brain or their GI tract while sitting quietly in a chair.
It's terrifying, honestly.
It really is. Now, just a quick epidemiological note for you listening. Keep in mind that the baseline normal can vary based on demographics.
Good point.
Yeah, women, younger individuals, and non-Hispanic Black patients actually tend to have slightly higher baseline platelet counts.
Which becomes really important context when you're looking at a borderline lab result in a clinical vignette. But I want to go back to that paradox you mentioned at the very beginning, the bleeding versus clotting paradox.
Oh, right.
Yeah.
The MCCQE loves to test this concept.
They really do.
So let's unpack this, because this is where the exam gets ruthless.
Yeah.
Wait, if we have a massive shortage of platelets, like a tiny budget, how on earth are we forming dangerous clots?
Right. It seems impossible.
It literally feels like having a shortage of bricks, but somehow accidentally building a massive brick wall.
What's fascinating here is the mechanism behind the shortage. In these specific paradoxical conditions, the platelets aren't just quietly dying off or failing to be produced.
Okay.
They are dropping in number because they are being hyperactivated and aggressively consumed. They're getting entirely used up to form inappropriate clots all throughout the patient's vasculature.
Okay, so it's a consumptive process. The platelets are essentially acting like a flash mob.
A flash mob, yeah, that's exactly it.
They all suddenly rush to form clots in one area or across the microvasculature, leaving the rest of the circulating bloodstream entirely empty. But wait, flash mobs happen for a reason. There's a trigger?
There is.
So what is the trigger causing the platelets to kamikazes like this?
Well, it depends on the specific syndrome, and you need to recognize the acronyms instantly. The MCCQE trap conditions where thrombocytopenia causes thrombosis include HIT, which is heparin-induced thrombocytopenia,
Right, HA.
and APS, antiphospholipid antibody syndrome. There's also DIC, disseminated intravascular coagulation, plus TMA, which includes thrombotic microangiopathies, and PNH, paroxysmal nocturnal hemoglobinuria.
Let's make sure we actually understand the why here. Take HIT, for example. Heparin is a blood thinner.
Yeah.
We give it to prevent clots. How does it cause a consumptive platelet flash mob?
It's a catastrophic immune misfire. In HIT, the heparin binds to a protein called platelet factor 4.
You have 4.
Right, PF4. For some reason, the patient's immune system looks at this new heparin PF4 complex and decides it's a foreign invader. So it generates IgG antibodies against it.
Okay, makes sense so far.
But here's the critical part. When those antibodies bind to the complex on the platelet surface, they don't just destroy the platelet, they intensely activate it.
Oh, wow. So the antibody flips the platelets on switch while simultaneously marking it for destruction.
Precisely. The activated platelets clump together, causing massive arterial and venous thrombosis, DVTs, pulmonary embolisms, strokes.
And because all the platelets are locked up in these massive clots, the systemic platelet count plummets.
Exactly. So if you see a clinical vignette with low platelets plus a DVT, a stroke, or a myocardial infarction, your mind needs to immediately jump to these consumption and activation syndromes.
Don't let the low platelet number trick you into thinking they can't clot. So that covers the consumptive paradox. What does this all mean for the underlying pathophysiology of thrombocytopenia as a whole? Why do these numbers drop in all the other cases?
To crush this on the exam, you need a conceptual framework. You have to mentally sort the pathophysiological causes into 4 distinct mechanisms.
Okay, let's build that framework. Mechanism number 1 is decreased production.
Right.
This is purely a bone marrow issue. If the megakaryocyte factory in the marrow isn't working, whether that's due to aplastic anemia, or leukemia infiltrating the space, or, I don't know, toxic suppression,
You simply won't produce enough platelets to replace the ones that naturally die off after their usual 8 to 10-day lifespan. The factory is completely shut down.
which brings us to mechanism number 2, increased destruction.
Yes. In this scenario, the bone marrow factory is working perfectly fine, pumping out platelets, but the product is being aggressively destroyed out in the peripheral circulation.
Okay.
And this mechanism splits into 2 very distinct paths for the exam: immune and non-immune.
Let's start with immune-mediated destruction. This is where anti-platelet autoantibodies come into play, right?
Correct.
These antibodies tag the platelets, and then the monocytes and macrophages of the reticuloendothelial system recognize those tags and just destroy them.
Exactly. We see this in primary ITP, which is idiopathic, but we also see it in drug-induced ITP, and crucially, secondary to other systemic conditions.
Like what?
Well, the exam will heavily test secondary immune destruction linked to HIV, hepatitis C, systemic lupus erythematosus, and even H. pylori infections.
I have to admit the H. pylori connection always seemed incredibly weird to me.
It is a bit counterintuitive.
Yeah, I mean, it's a stomach bug. Why is a localized gut infection causing the immune system to destroy platelets in the blood?
It comes down to a concept called molecular mimicry. Some strains of H. pylori express antigens that look remarkably similar to the glycoproteins on the surface of human platelets.
Oh, so it's a case of mistaken identity.
Basically, yeah. The immune system generates antibodies to fight the stomach bug, but those same antibodies cross-react and mistakenly attack the platelets.
That is brilliant and highly testable. So that's immune destruction. Then you have non-immune destruction. This isn't about antibodies at all.
No, this is about mechanical trauma.
Right.
Think of a patient with a mechanical heart valve. As the platelets circulate, they are literally subjected to sheer stress and physical trauma by the artificial valve, essentially tearing them apart.
Ouch.
Yeah, and you also see non-immune destruction in severe pregnancy complications like preeclampsia and HELLP syndrome, or the consumptive processes we just talked about like DIC and thrombotic microangiopathies.
The platelets are physically shredded or consumed without an autoantibody ever being involved. Okay, so that's production and destruction. Mechanism number 3 is dilutional. Now, tell me if this logic tracks. If a patient comes into the trauma bay having lost a massive amount of blood, and you pump them full of massive fluid resuscitation or standard-packed red blood cell transfusions, you're essentially watering down the concentration of the platelets they have left.
That is absolutely correct. packed red blood cells and crystalloid fluids do not contain viable, functioning platelets.
Right, of course.
So if you replace a patient's whole blood loss with just fluids and red cells, the total volume is restored, but the platelet concentration is radically diluted.
Which is exactly why massive transfusion protocols always require a balanced ratio of red cells, plasma, and platelets.
Precisely.
Okay, which brings us to the fourth mechanism, and this is the one that consistently trips students up. Redistribution. I love this one because the platelets aren't actually destroyed, and the marrow factory is working perfectly fine.
Right, they're not gone.
No, they're just stuck in traffic.
That is the perfect analogy. Normally, about 1/3 of your entire platelet mass is stored in the spleen at any given time.
Like a natural reservoir.
Exactly, but consider a patient with a condition that causes splenomegaly. For instance, chronic liver disease leading to cirrhosis and portal hypertension.
Because the liver is scarred, the blood backs up into the portal system, and that increased pressure causes the spleen to become massively engorged and congested.
Exactly. So instead of holding just 1/3 of the platelets, this giant congested spleen acts like a massive biological traffic jam.
Oh, wow.
It traps a huge percentage of the circulating platelets inside it. When you draw blood from the patient's arm, the CBC shows a low platelet count.
But the body technically has enough platelets. They're just all parked in the spleen and not circulating.
Yep, exactly.
So if we step back, recognizing these four causal mechanisms, decreased production, increased destruction, dilution, and redistribution, it gives you the architectural framework to logically solve almost any thrombocytopenia clinical vignette.
And now that we understand those internal mechanics, we have to translate this to the bedside. How does this patient actually present when you walk into the room or, when you read the exam prompt?
Well, remembering that threshold we discussed earlier is key. Patients with a count greater than 50,000 rarely have visible symptoms. You're mostly picking this up incidentally on a routine CBC ordered for something else.
True. But when they drop much lower into that severe territory, you're looking for the classic cutaneous signs of bleeding.
Right.
Petechiae, which are those tiny, non-blanching, pinpoint red dots, non-palpable purpura, and ecchymosis, which is essentially severe, widespread bruising.
And here's a crucial clinical differentiator you need to know for the wards and the boards. You need to differentiate the types of purpura. There is dry purpura, which is bleeding confined to the skin, and wet purpura, which is bleeding into the mucous membranes, like the inner cheeks of the mouth, the gingiva, or the GI tract.
And why does that distinction matter so much?
Because wet purpura is a massive red flag. Mucosal bleeding serves as a visible proxy for internal mucosal surfaces. If their mouth is spontaneously bleeding, it strongly suggests a severe risk for life-threatening intracranial or gastrointestinal hemorrhage.
It's way worse than just a bruise.
Yeah, it is a much more ominous sign than just skin bruising.
That's an excellent point. And while you're examining them, you are doing a full comprehensive physical exam because the associated physical findings often give away the underlying mechanism.
For sure.
If you palpate hepatomegaly or splenomegaly, you're instantly thinking about chronic liver disease, lymphomas, or that splenic sequestration traffic jam we just discussed.
Right. And if you feel enlarged lymph nodes, your differential diagnosis shifts heavily towards systemic infections, underlying autoimmune disorders, or hematological malignancies.
Yep. Now, for the initial laboratory evaluation of an isolated, unexplained thrombocytopenia, the standard battery obviously includes a CBC, but you must also order HIV and hepatitis C testing.
It is mandatory. As we mentioned, those viruses can silently drive immune-mediated destruction of platelets for years, and you simply cannot afford to miss them.
Exactly.
Now, here's where I want to introduce a classic, absolute favorite MCCQE trick question.
Oh, I know where this is going.
You probably do. Picture this clinical scenario. The lab results come back on your patient, and the platelet count is dangerously low, say 12,000. It's critical. You panic.
Naturally.
Right. You sprint to the patient's room expecting a hemorrhagic disaster, blood everywhere, wet purpura, the works. But the patient sitting in front of you is totally fine.
Not a scratch on them.
Exactly. They are drinking a coffee, reading a magazine, not a single bruise, no petechia, feeling absolutely great. What is going on?
This scenario raises a fundamental rule of medicine. Never treat the lab value in isolation. Treat the patient.
Always.
What you're describing is a phenomenon called pseudothrombocytopenia. It is an in vitro lab artifact. It's complete fake out.
So the machine isn't broken, it's just being fooled. How does that even happen?
When you draw blood into a standard purple top tube for a CBC, That tube contains EDTA, which is an anticoagulant designed to keep the blood liquid. However, in a small subset of patients, their blood contains EDTA-dependent agglutinins. When their blood mixes with the EDTA in the tube, it causes their platelets to aggressively clump together.
Oh, I see. And because automated cell counters often use impedance or optical scattering to count cells based on size, when a massive clump of platelets passes through the laser, the machine doesn't see 100 tiny platelets. It sees one giant mass and miscounts it as a single white blood cell.
Precisely. Or it just fails to recognize them as platelets entirely.
Wow.
Another variation of this happens if the patient naturally has giant platelets, which can occur in certain inherited platelet disorders like Bernard-Soulier syndrome. The automated counter might mistake those giant platelets for white blood cells as well.
So the machine prints out a report saying the platelet count is critically low, but inside the patient's actual blood vessels, the platelets are floating around individually, doing their job normally.
Yeah.
So for the exam is simple. Always review the peripheral blood smear.
Exactly. If the smear shows huge, irregular clumps of platelets, you instantly know the automated machine was fooled.
That smear is so important.
It really is. The smear is also vital for analyzing the size and morphology of the red and white blood cells. If you see schistocytes fragmented red blood cells, you're thinking TTP or DIC.
Right.
If you see abnormal blast cells, you're thinking leukemia. The smear is your source of truth.
Okay, so we've checked the smear. We saw genuine lack of platelets. We've confirmed it's true thrombocytopenia. Let's move from diagnosis to action.
Yeah.
What is the management strategy, and what are the board-relevant emergencies?
If the thrombocytopenia is mild, above 50,000, and the patient is completely asymptomatic, the management is generally conservative.
We don't just start throwing platelets at them.
No. You repeat the CBC to ensure it's stable and perform routine monitoring. We don't jump to aggressive interventions if they aren't bleeding and the count is in a safe tier.
But if they're severely thrombocytopenic and actively bleeding, or if they urgently need an invasive surgical procedure, that's when therapeutic platelet transfusions are explicitly indicated.
Exactly. Now, let's focus heavily on primary immune thrombocytopenia, or ITP, because the management framework here is incredibly high yield for the boards. Keep in mind, primary ITP is a diagnosis of exclusion.
Meaning you have to rule out everything else first.
Right. You have to rule out all the secondary causes like HIV, Hep C, medications before you land on primary ITP.
Let me summarize the logic of ITP treatment for you listening, because it is a very structured, tiered approach. Think of it like escalating warfare. First line, we just try to stop the body from destroying its own platelets.
Yeah, we use glucocorticoids to blunt the overall immune response, and we use IV.
IV is fascinating here. Intravenous immunoglobulin basically serves as a decoy system.
A decoy, exactly.
You flood the patient's bloodstream with exogenous antibodies. The macrophages in the spleen, which usually eat the patient's tagged platelets, end up binding all this extra IVIG instead. Their receptors get completely saturated.
They're just too full of IVU to eat the platelets. It inhibits the autoantibody production and blocks platelet degradation.
That's your first line. But what if that fails?
Then we escalate to the second line. We use rituximab, which targets the B cells that are producing the autoantibodies, or we use heavier immunosuppressive drugs.
Okay.
And if medical management fails, we perform a splenectomy. We surgically remove the spleen.
Wait, hold on. If this is an autoimmune issue where antibodies are tagging the platelets in the bloodstream, why does removing the spleen help? I mean, the spleen isn't making the antibodies, is it?
It's a great question. While the spleen does produce some antibodies, its primary role in ITP is acting as the graveyard.
The graveyard.
Yes. The spleen is packed with the macrophages that actually recognize the antibody tags and consume the platelets. By removing the spleen, you are removing the primary site of destruction. The platelets are still tagged by antibodies, but there's no longer a massive organ dedicated to filtering and eating them.
So you remove the destroyer. That makes perfect sense.
Yep.
And if even a splenectomy fails, we reach the third line of therapy. We've tried stopping the destruction. We've removed the site of destruction. So now we try to force the bone marrow to outproduce the destruction.
Exactly.
We use thrombopoietin, or TPO, receptor agonists. These drugs bind directly to the megakaryocytes in the marrow and aggressively stimulate them to pump out massive amounts of new platelets.
Stop the destruction, remove the destroyer, or force the factory to print more. It's a highly logical progression.
It really is.
And just to be thorough, For secondary ITP, the management is simply treating the root cause.
Right, like if lupus is causing it, treat the lupus with specific immunosuppressants.
Exactly. If H. pylori is driving the molecular mimicry we talked about, give eradication therapy antibiotics and a PPI, and you'll watch the platelet count naturally recover.
Now, we absolutely must cover the high-yield emergencies. These are the do-not-miss diagnoses that will kill a patient if you delay.
They are critical.
We've mentioned TTP, thrombotic thrombocytopenic purpura. The primary life-saving treatment here is plasma exchange or plasmapheresis.
Yes. In TTP, the patient is missing an enzyme called ADAMTS13, which usually acts like scissors to cut up sticky von Willebrand factor.
Right. Without those scissors, you get massive, uncut, sticky strings of von Willebrand factor floating in the blood.
Which catch all the platelets and form microthrombi. Plasma exchange is vital because you are physically filtering out the problematic autoantibodies and replacing the missing ADAMTS13 enzyme.
And the exam absolutely loves to make you distinguish between TTP and HUS, hemolytic uremic syndrome.
Oh, they do?
They look incredibly similar on paper. I mean, both have low platelets and schistocytes from microangiopathic hemolytic anemia, but their primary organ complications are fundamentally different.
That's the key differentiator. TTP predominantly features central nervous system microvascular thrombosis. The microvasculature of the brain is highly susceptible to these specific fibrin and platelet microthrombi. So you'll see a vignette with profound neurological symptoms, confusion, severe headaches, transient ischemic attacks, or seizures.
Got it.
HUS, on the other hand, notoriously affects the kidneys.
Right, because classic HUS is driven by the Shiga toxin from an E. coli O157H7 infection, and that toxin specifically targets the endothelial cells in the renal system.
Exactly. So HUS leads to acute renal failure. Brain symptoms point to TTP. Kidney failure points to HUS. It's a classic board differentiator.
And then there's HIT, heparin-induced thrombocytopenia, which we broke down earlier. Remember the paradox. The major complication here isn't bleeding, it's massive arterial and venous thrombosis. Stop all heparin immediately and switch to a non-heparin anticoagulant like argatroban.
Absolutely. So before we wrap up a clinical encounter or discharge a patient in a vignette, we need to establish the clinical safety guardrails. When are we calling for backup?
Any newly diagnosed or unexplained case of thrombocytopenia warrants a referral to a hematologist to firmly establish the etiology. But immediate emergent consults are required for TTP, HUS, HIT, or if the blood smear makes you suspect a severe bone marrow failure, like aplastic anemia or acute leukemia.
And if you have a pregnant patient showing signs of severe thrombocytopenia with elevated liver enzymes, HELP syndrome, or severe preeclampsia, you get an obstetrician on board immediately because the definitive treatment is delivery.
Let's also talk about patient education, specifically regarding activity restrictions. We mentioned the 50,000 threshold for surgical bleeding.
Right.
For patients sitting above 50,000, they're generally safe, but they need to be cautious and aware of the risks while participating in contact sports.
But if their count drops under 10,000, it is an absolute non-negotiable restriction from contact sports and any potentially traumatic activity.
Zero contact.
Zero. At that level, a seemingly minor bump to the head could cause a fatal intracranial hemorrhage.
We also need to educate them heavily on over-the-counter medications. Aspirin and NSAIDs are notorious for interfering with platelet function. Even if they have an adequate number of platelets, if they were taking daily NSAIDs, those platelets are functionally impaired.
Very true.
But here is a dietary trap that completely blew my mind. And it is the exact kind of obscure, seemingly irrelevant detail a test maker will hide in the middle of a long social history.
Oh, the dietary traps are sneaky.
Certain foods and drinks can cause immune destruction of platelets. Ginkgo biloba can interfere with platelets. But even crazier, quinine.
Yes, quinine-induced thrombocytopenia is a very real, highly documented phenomenon.
How does that even work? How does a beverage destroy platelets?
It acts as a hapten. Quinine molecules bind to the glycoproteins on the surface of the platelet, creating a brand new structure, a neoepitope.
Okay.
The patient's immune system suddenly recognizes this new structure as a foreign invader and generates antibodies that destroy the platelets. But the destruction only happens when the quinine is physically present in the blood to form that complex.
It is wild to think you could miss a board question because you didn't notice the patient's preference for drinking tonic water.
Right.
Tonic water contains quinine. A patient drinking gin and tonics every evening could present with a severe, sudden onset hematological profile. And if you don't explicitly ask about their beverage habits, you'll be chasing a ghost diagnosis.
It really emphasizes the importance of a truly comprehensive history. You aren't just looking for major diseases or prescription drugs. You have to look for everyday exposures that trigger these intricate immune responses.
So, to bring it all home and summarize the major takeaways, when you see thrombocytopenia on the MCCQE, remember the paradox. A low platelet count doesn't just mean a risk of bleeding. It can point to catastrophic consumptive clotting in conditions like HIT, DIC, and TTP.
And remember the absolute necessity of reviewing the peripheral blood smear to rule out pseudothrombocytopenia.
Don't let an EDTA lab artifact trick you into aggressively treating a perfectly healthy patient.
Exactly. And keep that tiered management framework for primary ITP straight in your head. First, stop the destruction with steroids and IVIG. Second, remove the site of destruction via splenectomy. And finally, push production with TPO receptor agonists.
It is undeniably a complex landscape, but by organizing the causes into those four distinct physiological mechanisms, decreased production, increased destruction, dilution, and redistribution, you can systematically work through any clinical scenario they throw at you.
You really can.
We started this deep dive talking about how a low platelet count feels like an intuitive mechanical plumbing problem, but it actually reveals a deeply complex, beautifully intricate, and sometimes completely paradoxical system. And to leave you with one final thought to mull over as you study, there's a fascinating prognostic statistic buried in the StatPearls research regarding mild thrombocytopenia.
Oh, right. A prospective study looked at patients with what we would typically consider mild, totally asymptomatic thrombocytopenia. Their counts were hovering between 100,000 and 150,000.
You might look at that lab result and think, well, it's just their natural baseline, they're fine, no big deal.
Right, but the study tracked them over time and showed those specific patients have a 12% probability of developing a full-blown systemic autoimmune disorder within 10 years.
12%. It completely changes how you view a seemingly benign, slightly low lab value. It's not just a number.
It really isn't. It suggests that a slightly low platelet count might just be the immune system whispering long before it finally decides to shout.
So keep your eyes peeled, remember your thresholds, and always, always trust the smear.